So what I wanted to talk to you about today was when you're in ICU, the sort of decisions you make around airway management. And you can extrapolate this out from when I'm in ICU to when I'm dealing with a critically ill patient who needs intubation, whether that's off the floor or in the emergency department, as well as in the intensive care. We'll look at some of the evidence behind what we know before pandemic and during pandemic and post-pandemic, and what directions we're heading with our practice. So some of the main decisions, I guess, will be who's going to intubate the patient, where you will intubate the patient, how you will intubate the patient, and what equipment to use. So just rolling back only a couple of years, and I'm glad Andy's here to answer some questions about this as well. So here's one of the papers that Andy and I and a bunch of other people had. We finished data collection just prior to COVID, but given that Vincenzo was the primary author and he works in northern Italy, and as you probably all recall, they got whacked by COVID pretty hard in that February, March 2020. By the time we got this published, I think it was somewhere towards the second half of 2020, and you might correct me if I'm wrong. And we looked at 3,000 roughly intubations in 29 countries in the critically unwell patient. And what we found, this is actually a really good paper. It was 10 times the size of any other data set, international data set ever published before, which was a real achievement to Vincenzo and the rest of the team. We found that at that point, 41% of intubations were using rocuronium, only 17% were using video laryngoscopy, about 60% were using a bag valve mask to preoxygenate, only 5% were using Thrive, as Georgie was just describing, and Drew. 45% had pretty bad outcome. So we had a primary outcome, which was a composite of severe hypoxia with SATs under 80, severe hypotension requiring vasopressive support, persisted for half an hour, or cardiac arrest. And 3% of patients who require intubation in the critically ill population actually have a cardiac arrest as a result of induction intubation. So what we know from that is, it's obviously a very risky procedure, has a high rate of adverse events, and those adverse events were related to first pass success and multiple attempts in intubation, and that correlated with hospital mortality. So what we found through our multivariate analysis was if you got the tube in first time, the patient was less likely to be dead at 28 days. So the most important thing with a critically ill patient you can do is get the tube in the first attempt, right? Which was never previously described. So the obvious question is, what makes it more likely to get the tube in the first time? So through another analysis, we found that having a consultant intubate made it almost twice as likely to get the tube in, therefore more likely for the patient to still be alive in 28 days. To have an anaesthetist do it as the primary specialist was, again, almost twice as likely, and to use a video laryngoscope. Now, this is data that's interesting to when you pull it apart, because there may be some regional variability, and obviously video laryngoscopy was not widely available in all 29 countries in 5 continents that we looked at. It's clearly more available now post-COVID because of the sudden interest in purchasing it from pretty much every hospital in the Western world. But those are the 3 things that really made the biggest difference to the patient. Problem we have if you only let consultants intubate is that in about 10 years' time, having a consultant intubate will actually make your chance of surviving worse, because you'll have a trainee that's never intubated a critically ill patient who's suddenly a consultant. So we need to have a balance between supervision and mentoring and experience gathering. What did we learn from COVID? So these were the guidelines that we put out in the MJA, which John mentioned earlier. We wrote them in March 2020. So I think they were online March 2020 in the MJA. We had about 5 days to have them in. Obviously endorsed by all of the airway societies and groups mentioned there, and I think not restricted to those. And then they were disseminated widely across the country. And what we suggested at the time was that you optimise pre-oxygenation and you have a balance between patient safety, which was most experienced operator, best attempt, optimal situation versus staff safety, so vice-like grip. At the time, we thought aerosol generating procedures was a huge risk to the staff, and there was a balance between getting the operator as far away from the airway as possible with the video laryngoscope, although in hindsight that's ended up being quite lucky because it has been shown to increase your chance of first-pass success. We recommended high doses of rocuronium and the use of specific team structures and cognitive aids. When we looked at, here's an example of a neatly put together video by the team that sort of describes what we were recommending at the time. So this is probably not unfamiliar to all of you, having been through the last couple of years, and I'm sure that you can see we've got a fairly minimise the number of people in the room to just 3 with specific roles. You have an airway operator with a dedicated assistant, the team leader managing it. Usually there'd be a runner at the door that you can't see in the video, as far away from the patient as possible. And we're going through a series of checks to enable rapid, safe intubation. And then there was some clamping of circuits and connecting of viral filters and specific other equipment, as most of you would remember. About 6 months later, so after the alpha wave and I think the second wave, we looked at what actually was done with the critically ill patient in Australia and New Zealand with COVID. So we went through 69 of the ICUs across both countries, and we described the airway management that occurred in the COVID patient. So if you think back to the JAMA paper, we had the Intube study, what was being done immediately before COVID. Now suddenly you're seeing 94% of intubations using video laryngoscopy, the use of checklists, cognitive aids, spotters, and specific simulation-based training occurring in almost all intensive cares in Australia and New Zealand. We saw that specialists were performing almost all intubations, that in ICU, and this was more to do with availability than anything in different hospital dynamics, but intensive care specialists perform about 2/3 of the COVID intubations, and anaesthetists performed about 1/3, which anaesthetists were more likely to do it in public where they had dedicated teams, whereas in private it was almost always intensivists. And there was a reliance on airway guidelines with 94% of public hospitals. And as you can see from their practices, they're all based on our published guidelines, which was great to see such an excellent uptake of a standardised approach to airway medicine. It's a pity it took a pandemic in order to get people to do it. So what does this mean moving forward for 2022? There'll be some discussion, I think, throughout the day on this, and there's been some great recent publications, including Tim Cook and some of his colleagues have put out a Cochrane review on video laryngoscopy just recently. But there will be an increased use of video laryngoscopy, hopefully now, not just within the ICU, but for all intubations of the critically unwell patient. Senior airway expert to intubate should be a question that's asked more often. We're seeing an increased use of rocuronium already that should persist in the critically unwell patient. There's a recognition of the risk associated with intubation, which should stop us all before we start the process to think about what the possible outcomes are and how we can mitigate that risk as best as possible. Hopefully some of the strategies to do that will include an increased uptake of things like checklists and cognitive aids and specific team structures. Guidelines are a bit of a bugbear of mine. There's far too many guidelines that exist. This is an article we've got coming out in a couple of weeks, I think it's next week or the week after, which Anaesthesia asked me to write on the appearance of human factors within airway guidelines, which has Stuart Marshall and Laura Duggan and Marianne Turner involved. That's the number of guidelines that have been published since in the last 5 years. So there was 26 of them there, which is too many. And what you need to ask yourself is which guideline should our staff be using? And it would be a lot easier if there was just one. I tell my staff this is the guidelines that we use for our critically unwell patients, which is the difficult airway ones, which Andy and colleagues published just again prior to the pandemic. One of the, with the COVID patient, I think is the only exception we have at the moment where we still have COVID guidelines. which vary only slightly. And Andy's guidelines, the Difficult Airway Society guidelines, do a number of things well, but one of the things that impresses me most is the appearance of team structures that appear in human factors in the guidelines. So it's not just about the order in which you put the drugs in or the equipment you choose, but where do we stand? How do we perform as a team? How do we prepare as a team? How do these processes help to enable us as a team to get the best outcome for the patient? And again, this will be one that we discuss sort of more broadly in this paper coming up next week. But one of the things that we do find is that human factors are appearing significantly more in guidelines. The frequency is increasing. There's still a bit of work to do, and one of the things that would be good would be the appearance of cognitive aids and checklists with all guidelines. Video laryngoscopy in the ICU is something that, for some reason, has always had contentious sort of zealots having discussions about prior to COVID. I think maybe the barriers to using video laryngoscopy has been broken down a lot by COVID, because people were forced to use them, or they felt safer using them. As an anaesthetist, primarily, for me, you were always sort of taught, well, you don't need that unless there's a difficult airway. But I think when I'm supervising registrars or looking after a critically unwell patient, there is something reassuring about having, the ability to watch on the screen what's happening. It enables greater supervision and teaching of the trainee. Now that there's evidence coming out that it's going to reduce the risk of esophageal intubation or improve first-pass success, I think it's hard to fight that this is the way forward. There's a problem with all of these, the research on video laryngoscopy is it's always quite heterogeneous. It's different patient groups, it's different operators, it's different devices. So how do I take this study, which looked at a different type of, or a different blade of video laryngoscopy, and compare it to this study, which was in an obese population versus a pregnant population versus a trauma population or pre-hospital. But once, as all the evidence is starting to get put together more frequently, such as this recent review that came out, I think, a couple of months ago, is certainly showing a significant impact of VL in improving things like first-pass success. The balance about who intubates the patient is a tricky one, whether you're pre-hospital, ED, ICU, in theatre. We all need a volume of practice to become experts, and the volume of practice with laryngoscopy is really important. It's no different to flying hours as a pilot. We know that, and it can't all be grade 1 views with edentulous patients ramped well in theatre, having a lap collie that are pre-oxygenated. You could spend 20 minutes stuffing around before you get the tube in. So you need to give trainees some exposure to really difficult procedures. So that's a balance, and I think that comes with knowing your staff well, with having longer rotations. For example, we have another study that came out in critical care and resus last week looking at airway competency in ICU specialists, and one of the facilitators for airway competency and perceptions of skills and confidence at certain intubations, such as awake fibre optics or surgical ones, was the prolonged training in theatre. So intensivists who have only spent 12 months in theatre don't have the same competence and confidence as those who have spent 4 or 5 years. So having a longer relationship with your trainees, longer rotations, letting you get to know them and giving them more rope to work with when you're supervising them is really important. And this is a particular challenge when you have a patient who you know is going to be really difficult, and sometimes you have to make the decision, well, actually think this intubation might be beyond them, and you have to step in and hope they can learn from your performance as much as possible. And the last thing I was going to talk about was the concept of difficulty. I'm not sure if Sheila's talking today, so hopefully I'm not stealing her thunder, but good. The physiological difficult airway is something that we're talking more and more about. So the airway may not be that anatomically difficult, but the patient in itself is, whether that's due to right heart failure, whether that's due to acidosis, hypoxia, aspiration risk, and so on. And these patients are equally important to plan and prepare for, and just be hypervigilant of how much time you have. This is a graph from that last paper that Sheila and I had, just showing that the desaturation time in the apneic patient is actually significantly worse in the obese patient than the critically ill patient or the child. So just having that concept in your mind of which patients are the ones where their airways physiologically will be most difficult. So just to sort of poll the audience a little bit, we have a 60-year-old man coming back from theatre after coronary artery bypass surgery. For those who work in ICU, this would be pretty common. 120 kilos sleep apneic patient, grade 3 intubation for Drew yesterday in theatre, so very experienced anaesthetist. Extubated without any issue the first night, but unfortunately has aspirated this morning and needs to be rapidly reintubated. So in your unit, or if you can put yourself in the intensive care of your hospital, who's going to intubate that patient and what equipment should they be using to do that? And the second one to think about, you have a 30-year-old male sent to ICU to observe overnight, fever, sore throat, trismus, painful swallowing, tooth extraction a week ago, significant facial swelling and infection in the neck, worsening dyspnea and stridor in the morning, suddenly needs intubation. So how are you going to do that? Who's going to do it? Where are you going to do it? What technique are you going to use? And I think that one specifically is still the one that often gets done wrong in ICU, because there's this failure to consider awake intubation. And so really it's where we're headed now is VL, cognitive aids, training, team structures, universal approaches. For the instance of time, I'm going to say thanks, and I'm going to give a shout out to Dr. Begley here for winning the award with his aerosol box study last night. So well done. That was an excellent paper that he put out through Safe Airway Society, which was great. Thank you.